This woman is being taken to the hospital, and this is the very, very tragic state of the U.S. healthcare system. So, pretty sad.
Yeah, that is very sad.
It's not like these people, they don't want this. Choosing, to abuse drugs or, homeless because they're choosing to be or anything like that. This is the average American. This is an average Arkansan. That's what bothers me so much, is that, not that I don't have compassion, but there's some people who choose
9:14,
drugs,
9:12, 9:13, 9:15, 9:20.
results but this is
9:13, 9:16, 9:20, 9:12, 9:14.
They're in the squeeze. They don't qualify for assistance, but they can't afford health care or health insurance. It's our average Arkansan that we're seeing today at this class.
Number 6 going to the hospital.
This is, I have lost track, 6 or 7.
That have been taken to the hospital. And you were saying that the average Arkansan is not qualifying for Medicaid?
I'm just saying this is the average Arkansan working, our neighbors,
right,
that don't qualify for any kind of assistance but can't afford health insurance,
right,
because it's either not provided, or even if it's provided, sometimes they can't afford it.
Right. I met a woman over here who is working full time,
but this is our middle class, or average, Arkansan that can't afford health insurance. I have an innumerable number of people that I work with, and well, not so much work with because I work at the VA, but that I know that can't afford health insurance. Even if it was offered, they couldn't afford it. Economic times are hard, and this is the rural average Arkansan that we're seeing here today. Majority. Now I've seen a few people that are not, but the majority is that class of people. Our neighbors, our friends, our co-workers that are out there that are in
falling
the squeeze.
right through the cracks.
They're in the squeeze.
Right.
They're in the squeeze. They're working hard, but they can't qualify for assistance. And the only way sometimes they can get things is quit their job.
Right. Some system.
9:25, 9:19, 9:18.
You look very upset.
9:17,
I am.
and 9:26.
It bothers me that these are,
9:26,
what I
9:17,
consider our neighbors,
9:18,
our
19,
families.
Right.
9:25.
Do you know why this woman was taken to the hospital?
Yes, she was having chest pain.
Right.
And she was having an abnormal heart rhythm and abnormal EKG.
And how long had it been since she'd seen a doctor?
I'm not exactly sure how long, but she was out of all her medicines.
She was out of all for a period of time?
For a period of time, which has probably resulted in her having these symptoms.
So her treatment now will probably cost more than had she been able to just get her medicines.
Oh, going to the hospital, you could provide a lot of outpatient treatment for just
9:30,
one hospital visit.
9:31, 9:32,
Yeah. The economics,
9:37.
see, we pay for people to go to the hospital.
Right.
We pay for that acute care,
9:37,
but we won't pay for them to be
9:32,
prevented. We won't pay for this situation to
9:31,
be
and
prevented.
9:30.
We won't pay for medicines that they need to prevent them going to the hospital necessarily, unless they qualify for some assistance. But our system is based on acute treatment and not prevention and not chronic medical treatment. People with chronic medical problems fall through the cracks. I mean, I've seen patients that, have a chronic medical problem, they just need medicines. We won't pay for the medicines for their chronic treatment or to keep them from getting worse, but we'll sure pay for the surgery they need when it gets really bad. We'll sure pay for the procedure that they need when it gets really bad, but we won't pay to prevent it from getting that way. We won't pay for dietitians to see
Monica
diabetics so that their
Lewis,
diabetes doesn't get bad, so that they don't get cardiovascular disease, so that they don't end up with a bypass.
patient waiting
She'll
here.
pay for the bypass.
Monica,
We're waiting until they really get really sick and need acute care that we're paying for. But the consequence of that is an unhealthy population.
Dr. Garner, what in your opinion might have happened to this woman if she hadn't come to this clinic today?
Well, we're concerned that she was having a heart attack, and if she had a heart attack, the potential could be death. That would be the ultimate. If you also could have a heart attack that resulted in you're not getting enough blood flow to your brain, which would result in a stroke. There's damage to her heart, so that she's got such bad heart failure that she can't walk across her house without being short of breath. Those are all consequences of a heart attack. It's damage to the heart, such damage that you end up falling out and having a stroke, or falling out and having hypoxic brain injury, or falling out and dying.
Right. Okay.
Does this strike you in any way differently than it does in your normal practice when situations like this arise?
Well, see, I have an advantage. I work at the VA where we do the best primary health care in the world, and we don't, bad things can still happen, but we do great primary care. We do great prevention, and we do everything that we can to prevent this from happening. And that's the difference. Where I work, it's still bad. Some bad things happen. Don't get me wrong. Some people can have, consequences of disease, long-term disease. But we do everything in our power: screenings, cholesterol, making sure they get their medications, everything in our power to prevent this from happening, and to prevent them from even getting this disease process in the beginning. So primary prevention and secondary prevention. These people are not really getting that in our healthcare system today. The focus is on treatment after you have a serious health problem, not preventing those health problems from happening. And that's really the focus of primary care. But see, so many people can't even get to that first level of primary care because they're in that squeeze where they don't qualify for assistance. They can't afford to go to the doctor, and they can't afford health insurance. They're in that squeeze. So, but we need primary prevention and we need secondary prevention, not just treatment after somebody really gets sick.
And the only way we have that is if we have guaranteed and affordable health care.
Well, I think I'm not a politician or a policy maker, unfortunately, or maybe fortunately. I guess I do better as a physician, but I think there's a lot of different things about solving that problem. Maybe we need more clinics out there that are affordable. Maybe we need to change the system so that people aren't spending so much on defensive medicine, so that we can have more that we can be able to focus on primary prevention. But I think to me it all revolves around what are your goals? Because that's what I talk to patients about individually, but I think it also affects the macro system as well. Are we going to wait and pay to treat people when they're really sick, and we've waited until it's almost too late to turn that around? Or are we going to focus our efforts on prevention and treating people so that they don't have the consequences of hypertension and diabetes? Now, there's still going to be some people out there getting sick. That's not a cure, but are we going to focus our efforts on, early identification of disease, diet, exercise, all those kind of things, and have a healthy population? Or are we going to focus our efforts on just paying for and treating when they get really sick? Right now, our system is focused on just waiting until they get really sick, and then we pay for their treatment.